The focus of this module is on racism, structural discrimination, and health. To get us started, we'll focus on a few definitions because often these terms are used interchangeably and there's a lot of overlap between them. Racism is sort of the umbrella concept here. Specifically, according to Clark and colleagues, the beliefs, attitudes, and institutional arrangements and acts that tend to denigrate individuals or groups because of phenotypic characteristics or ethnic group affiliation. And so if racism is the umbrella term related to a host of different practices, beliefs, and so forth that are perpetrated due to individuals' racial or ethnic characteristics, prejudice is a little bit more specific, referring to the negative or stigmatizing beliefs about a group possessed by another group. And discrimination refers more specifically to types of practices. So it's sort of prejudice enacted through practices ranging from social distancing to aggression. Kamara-Jones' typology of the levels of racism or discrimination is really useful as an anchor, a starting point to organize the ways in which levels of racism play out differently. Types of behaviors and discriminatory practices can be identified in different ways, categorized as follows. The structural, institutional, or systemic discrimination refers to the ways in which systems operate to result in differential access to resources. And these systemic processes may be normative and sometimes legalized. And what's crucial here is there's not necessarily an identifiable perpetrator or a single individual agent that can where the action is situated. It's more diffuse across the range of structural arrangements and systemic practices. Also, the way that structural discrimination manifests can be as inaction in the face of need. And of course, the federal government response to the Katrina hurricane is a perfect example of where the failure to respond in a timely and sufficient manner was deemed to reflect institutional racism to a great extent by many observers, because the insight being that if the counterfactual had been true and if the population that was so dramatically affected by that natural disaster was white or of a different class, then we would have seen a different level of responsiveness on the part of the government. The second level of Jones's typology is interpersonal discrimination, or personally mediated discrimination, which can be reflected in terms of acceptance or internalization of negative attitudes that manifest as intentional or unintentional acts towards others, based again on phenotypic characteristics or ethnic affiliation. They can be acts of commission or of omission, reflected in things like overt acts of hostility to dehumanization, invisibility, annihilation of a group, lack of respect, suspicion, scapegoating, etc. And the third level of Jones' typology is the internalized racism, referring to how negative stereotypes are internalized and accepted and lowered concepts of self-worth by members of a stigmatized group. In each of these cases, each of these levels, they all reflect to varying degrees and perpetuate societal norms and ideologies, whether they're very explicit or instead more insidious. And in this module, we'll be focusing on the structural forms of discrimination and their manifestations as they relate to health. Here we can see an example of how structural racism leads to major disparities in health-related resources, here specifically education. So you can see that across all different races here, race and ethnicities, you see really significant differences in educational attainment. And specifically, here's the category for whites. Overall, you see much higher levels of graduate level education relative to racial ethnic minorities such as blacks and Hispanics, less so relative to Asians. So with educational attainment, in some ways, the picture is not a clean story, of course, of whites versus non-whites in terms of attainment. What you do see here is that low levels of graduate level education among blacks, Hispanics, and Native Americans, and very high degrees of attainment below the level of high school. Similarly, you can see here just black versus white disparities in unemployment, and of course these figures as late as 2003 don't reflect of course, the impact of the most recent economic recession on racial differences in employment status. You can see the persistence over a 30-year period, though, of really stark racial disparities in unemployment rates. Also reflected in median household net worth, you have very significant disparities between blacks and whites in overall net worth. You see, when you look specifically at income levels, really stark disparities, and that get even more magnified when you take into account household wealth, not just annual income. You see racial disparities with respect to health insurance, where Latinos are particularly disadvantaged, largely because majority of the all of the non-legal population does not have access to health insurance, and Latinos are overrepresented by individuals who do not have legal status in the U.S. But they're not alone, because you can see that Alaska Natives and American Indians are right behind, despite no issues with legal status, and African Americans similarly have high prevalence of being uninsured in this country. When we think about the drivers of these disparities in health-related resources, we start looking at even farther upstream to structural factors that are operating in a very racialized way and producing significant disparities in outcomes. And of course, the mass industrial complex around incarceration is an obvious example of structural processes that are producing really racialized differences in both the experience of incarceration and then the subsequent outcomes as a result, impediments to employment, to housing, long-term economic security, and so forth. So these are not any longer very novel statistics, but I will go through them briefly just to animate some of the ways in which we see evidence of real racial disparities in incarceration in the U.S. African Americans are only about 13% of the U.S. population, only about 15% of U.S. drug users, but over 35% of those arrested for drug offenses. And 42% of Americans in federal or state prisons and local jails are African Americans, and 43% of prisoners on death row are African Americans. So you can see when you have almost half of the prisoner population on death row represented by a population that only constitutes 13% of the U.S. population, you have a real overrepresentation of a population in incarceration. And one facile explanation of this disparity between representation of the overall population and representation in prison is that this population behaves more badly. This population is just disproportionately constituted of criminals and so forth. But the reason why we need to not take that explanation at face value is because of rampant evidence of racial discrimination operating within the judicial system to produce these disparities. Another important way of understanding racial disparities in incarceration in this country is to look at the U.S. In terms of the overall population and relative to other countries. So here you see incarceration rates by race in the U.S. In 2004, and you see real racial disparities that get even more extreme when you restrict the population to males, and get even more extreme when you restrict it to young males. Here you see males aged 25 to 29, and the racial disparities get even more stark in this subpopulation. And you compare the population of incarceration in the U.S. relative to elsewhere. So here you have black men under black adult men per 100,000 population incarcerated in 2004 under George Bush. And also here you see the population of black adult men incarcerated in South Africa in 1993 under the apartheid regime. So there you're seeing what is a really dramatic contrast, especially given the contrast between these two countries of the total population of each represented by black men. The contrast gets even more stark. One of the interesting tangential implications of mass incarceration, as it's highly racialized, is the possibility that then what we're looking at in the general population of non-incarcerated men, black men, is better than it looks better than it really is, because we're not accounting for the extent to which the black male population is in institutional settings where we don't capture them in our surveys. This particular study highlights the fact that among male high school dropouts between 75 and 79, born in those years, 68% of blacks compared with 28% of whites had been imprisoned at some time by 2009, and 37% of blacks compared with 12% of whites were incarcerated that year. What this means is that by the time they turn 18, 1 in 4 black children will have experienced the imprisonment of a parent. More young black dropouts are in prison or jail than they have paying jobs. Black men are more likely to go to prison than to graduate with a 4-year college degree or complete military service. And black dropouts are more likely to spend at least a year in prison than to get married. So here you see a contrast of outcomes in the black male population in the U.S. And what it means is when we track the progress among non-incarcerated, non-institutionalized populations as we do, we actually have an overestimate of black progress with respect to education, employment, wages, and voting participation, because the denominator is not taking into account the fact that there's a huge proportion of this population that is not in the general public engaging in these activities, but rather is experiencing incarceration or its aftermath. Much attention has been paid to the systemic drivers of overall incarceration levels in the U.S. That are relevant, of course, to the racialized nature of that incarceration as well, pointing to the recency of the U.S. prison boom, the fact that until the 1970s, incarceration rates were stable and then dramatically doubled in the 80s and again in the 90s. During this time, you're seeing a decrease in incarceration of violent offenders, so this is not an increase in violence in the population and therefore manifesting as greater incarceration. What it reflects is a dramatic increase in nonviolent offenders. And the critical analysis of these processes is the idea that what we're seeing is incarceration is increasingly used as a solution to social ills and, very importantly, as a source of industry and financial gain. The long-term implications of incarceration disproportionately affecting blacks is really starkly illustrated in the PAGER study, audit study, looking at employment callbacks for blacks and whites with and without a criminal record. And in this audit study, the mock applicants were matched on all criteria. They were made to look equal in all respects. The jobs they were applying for did not require previous experience or education above a high school level. And what they find is with random assignment of whites and blacks to having a felony drug conviction on their resumes or not, that you see that when they contact employers, the impact of having a criminal record on blacks and whites on the callback for the employment opportunity is really, really dramatic. So here you see that for blacks, having a criminal record reduced the likelihood of a callback relative to not having a criminal record, as it did for whites. But what's most striking here is that whites with a criminal record got called back more often than blacks without a criminal record. And so it really shows the overwhelming impact of race on outcomes for blacks, despite having the lack of a criminal record in this case relative to whites. Another major mechanism of structural discrimination with implications for health-related resources is housing discrimination. Here are two examples of the processes by which housing discrimination occurs. The first is steering, which refers to discrimination among real estate agents against potential buyers or renters in particular communities based on their race, ethnicity, or other characteristics. Redlining refers to discriminatory lending on the part of banks, and traditionally refers to the refusal of a bank to lend money to finance a house at a black neighborhood. And this continues today, even though it's different than as it was back in the day when banks actually circled neighborhoods in red, indicating where they would not lend. Here it's a little bit more subtle, but it does manifest very starkly in terms of lending disparities between black and white neighborhoods, even with comparable income, and also between black and white applicants. Here is an illustration of steering based on a map of an audit test looking at evidence for steering in the Detroit metro area. The green dots are white testers in white areas, denoted by the white background. These are white neighborhoods. And the black testers are in yellow dots in predominantly black or red neighborhoods. And you can see that the clustering here really reflects the evidence of how the real estate agents are steering whites to particular areas versus blacks to others, based only on the color of their skin, everything else being held constant. Evidence of redlining. Here's the percentage of mortgages denied by banks by the borrower's race and ethnicity. You see here that Hispanics, blacks, and American Indians are at a dramatic disadvantage, and that this is true, that they're more likely to be rejected for a home loan regardless of their income. So here, even when you stratify by income group, you see that at every income level, including the upper income level, blacks and Hispanics, but especially blacks, are more likely to be denied a home loan regardless of their income. Housing discrimination and other sorting processes, and there are many other sorting processes, are what produce dramatic levels of racial residential segregation, which is still very pervasive today, and it's a very stark manifestation of structural discrimination, among other things, that has very important implications for access to material resources that we assume to be relevant for health. It's also one of the few, I'd say, indicators of structural discriminatory processes that are fairly well studied in the field of health disparities, simply because it's an exposure that is relatively easy to measure versus other forms of structural discrimination. Because you can't ask somebody directly in a survey about their exposures to structural discrimination, because seldom do they have sufficient information to be able to deduce the extent to which that's occurred to them personally. And when we use other measures that capture a process operating at a more of a group level, a contextual level, we're able to impute an individual's exposure to that based on their proximity to that group level phenomenon. So if you live in a hypersegregated neighborhood, we can assume that you have individually been exposed to residential segregation. One of the most common measures used to characterize residential segregation is the measure of dissimilarity. And simply what it means is shows how separate two groups are from each other in a particular metropolitan area. And therefore, it's considered in the lexicon of discrimination measures a measure of evenness. The interpretation is fairly simple. Here you see that 65% of blacks in 2000 would have to relocate to a different neighborhood or census tract in their overall metropolitan area in order for whites and blacks to be perfectly racially integrated. Overall, a score of 60 is considered to be very, very high, and you can see that both in 1990 and 2000, blacks were far above that cut point, although Hispanics are not far behind, and Asians also experience a pretty high level of segregation. However, it's consistently true, despite different kinds of measures used and years in which this is tracked, that blacks are uniquely exposed to residential segregation. Another important signature feature of residential segregation experienced by African Americans is the extent to which it overlaps or intersects with socioeconomic status. So relative to other hypersegregated neighborhoods, African Americans are much more concentrated in poor neighborhoods. There was one study of over 170 large cities in the U.S. and showed that there was not one city where whites as a group lived in comparable ecological conditions to blacks in terms of things like single-parent households, poverty levels, and so forth. It has real implications for our ability to compare blacks and whites because the conditions in which they're living are so dramatically different. There's not enough overlap to be able to isolate the effect of race above and beyond things like neighborhood conditions, socioeconomic status, and so forth. It's also true that middle-class blacks are not inured from experiencing residential segregation. So it's estimated that about 80% of black middle-class households are located in predominantly black communities, and interestingly and importantly, within 4 or so blocks of poor neighborhoods. So again, suggesting the extent to which socioeconomic status is not a sufficient mechanism to enable African American families to exit poverty entirely because of mechanisms like persistent residential segregation. I mentioned that residential segregation is one of the more studied structural forms of racism that we look at with respect to health, and it's considered one of the upstream fundamental causes of racial health disparities. The kinds of pathways assumed to be operative there refer to things like education and employment opportunities, which then, of course, block mobility, access to resources, and therefore impact health. At more of a collective level, though, residential segregation can be a driver of disinvestment in a community, therefore depriving a neighborhood of important resources and services, including things like health clinics, but also resources that are in services that are very directly relevant to health, like access to healthy, nutritious food that's affordable and so forth. Residential segregation can also produce differential exposures to noxious social and physical elements that can be relevant to health, of course. And also, residential segregation has important implications for the socio-demographic composition of a neighborhood and the social contact that ensues. Now, what's interesting here is that it's not necessarily true that concentrations of individuals in neighborhoods on the basis of race and ethnicity is necessarily bad for health at all in and of itself. And in fact, there's a decent amount of evidence suggesting the opposite, that ethnic concentration or racial concentration is protective for health if you can disentangle it from the fact that it often travels with economic disadvantage. And the ways in which residential segregation has been examined with respect outcomes include things like all-cause and cause-specific mortality, infant mortality, and also things like tuberculosis, just by virtue of hypotheses related to transmission of infectious agents. More of the etiologic interest now relates to hypotheses about stress, exposure to discrimination, exposure to resource disadvantage, and therefore looking at outcomes that transcend a lot of different etiologic mechanisms makes sense. There's also a lot of attention to things like mortality outcomes because of the data availability and the use of publicly available data to look at the associations with things measured at the aggregate level, whether it's in ecological studies or otherwise, but where we're actually collecting data on and characterizing communities in terms of their residential segregation. Other examples of structural discrimination are worth mentioning, in many ways operating indirectly, and therefore harder to necessarily see at first glance whether this is discrimination or not, whether this is an intentionally about or whether there is motivation to marginalize or disenfranchise a particular racial ethnic group. But what you can look at is the effect of the outcome on that group, and ask if it's disproportionate, and ask if it would have manifested as it has if other groups were disproportionately affected. So if you look at things like the deindustrialization on work options, and look at the way in which this is a systemic process that has differential effects on some subgroups of the population versus other. Things like post-war interstate highway systems on city living conditions. If the composition of the parts of the city impacted were different by these huge infrastructural social changes, would they have been played out differently? Would they have had more protections to maintain a sense of community, access to resources, and so forth on the populations affected by these major structural interventions? Voter ID laws, of course, is a very important example of structural discrimination, really salient given recent changes. The overturning of civil rights legislation to protect subgroups of the population defined in terms of race and other characteristics as to their ability to engage in the ultimate form of civic participation, which is voting. And now that we've seen the revoking of these laws set up to protect minorities from the effect of disenfranchisement by voter laws restricting things like the availability of voting early, the ability to vote without presenting a government-issued ID, and so forth. The obvious interpretation of these maneuvers is that this is a cynical tactic to intentionally disenfranchise people who are disproportionately likely to vote for one party versus another. But it's also has a huge historic precedent And the fact that there is a history of federal intervention to monitor states in trying to enact voter laws that would have the effect of disproportionately disenfranchising certain minority groups suggests nobody's being fooled by the extent to which this is still operative and is a highly, highly racialized tactic. And just even more broadly speaking, the geography of behavioral risk factors is a really good example of structural discrimination, how you see corporate entities deciding where to allocate certain kinds of advertising and outlets for their toxic goods. It suggests a sort of patterning that is not random with respect to racial composition. One example here is targeted advertising of alcohol in New York City, and you can see here that this is a really non-random distribution of alcohol ad prevalence across the city, the highest prevalence in areas that are concentrated with racial ethnic minorities. The same is true for fast food concentration outlets in the city. And here you have the colors here represent the percent black in the greater New York area, and the open circles are Starbucks, and the closed circles are Kentucky Fried Chicken, and this is a very non-random distribution. So, of course, there are many arguments to simply say that this is marketing and outlets that reflect demand, and that demand is differentially spread across racial ethnic groups, and racial ethnic groups differentially distributed with respect to geography, and that is perhaps true, but the effect of this is a real different saturation of exposure to a noxious food substance that's bad for health that is very, very racially patterned, even if there's not somebody with a behind closed doors who's trying to orchestrate some kind of evil conspiracy. Despite some examples, some notable examples with respect to racial residential segregation and health, overall institutional racism is again very understudied. We do have population-based studies either at the ecological or multi-level, and using usually indices of segregation or proxies for that, like racial ethnic composition, percent black, percent Hispanic, etc. But overall, it's rather relatively understudied compared to other types of discrimination. One exception, I'd say, is with respect to healthcare outcomes. And healthcare outcomes are interesting because, in some ways, discrimination operating at the healthcare level of healthcare and health systems is, in many ways, an intersection of structural discrimination processes and interpersonal discrimination. In that there are agents whose biases are operating and leading to differential outcomes for blacks and whites, but the person who's experiencing these biased behaviors is not necessarily experiencing it in terms of bias. They're just experiencing an entire system that, through the collective operating of lots of different individuals' biases and so forth, are experiencing different outcomes as a function of their exposure to the institution, not necessarily to their individual exchange with the provider. What you see when you look at racial differences in healthcare is dramatic differences in access overall, reflecting largely socioeconomic status, or presumably, at least in part, socioeconomic status. But what you also see is differential quality of experiences and outcomes that are much more easily attributable to discrimination, and in fact, in many ways, hard to attribute to anything but discrimination. And the critical nature of healthcare outcome differentials by race led to a major IOM report called Unequal Treatment, which was congressionally mandated to focus on health disparities in a healthcare setting that cannot be attributed to access-related factors or to differential clinical need. So they were really focusing on the operation of an entire healthcare system and looking for evidence of discrimination, which could reflect biases, stereotyping, uncertainty in clinical communications, decision-making, cultural differences, and so forth. What they found out of this study, controlling for all important differences like access to insurance, income, age, comorbidity, symptom expression and severity. So this is not about different people presenting with different symptoms or expressing them differently and therefore getting treatment. When you control for all these background factors, they found that African Americans were significantly less likely to receive appropriate cardiac medication, undergo coronary artery bypass surgery, receive dialysis, kidney transplantation, receive high-quality basic clinical services and antiretrovirals. And of course, all of these differences have really immediate and direct consequences for survival. And of course, a secondary consequence may be the impact of differential treatment on individuals' willingness to use or trust and have confidence in the services they do access. And again, the healthcare context is one where you really see, as elsewhere, intersections of structural factors with individual bias being operative. But the important point here is the fact that this is discrimination operating in a very insidious way for the target or the receiver of that discrimination, with really important implications for their access to critical health-related resources.